And so welcome everyone to an exciting new webinar series featuring Lisa Kendall. I'm going to go ahead and stop sharing our title slides so that you can say hello to us. We can say hello to you. We suggest that you select Speaker View. You have an option in the upper right-hand corner of your Zoom screen to go either Speaker View or Gallery View. Gallery View will give you that Hollywood Squares look, which might be really overwhelming because there's a lot of people on the system today. If you choose Speaker View, whenever there is someone's image, it will show the person speaking, kind of like I am right now. If you are on Speaker View, I'm going to give you a couple of things that I want you to focus on before we get started introducing Lisa and moving into our presentation today. And that is a little bit about how to use the system. I'm going to ask that everybody mute, please, if you would be so kind. Make sure that all of you are muted, because all you really need to hear right now is myself and then Lisa, who will be our featured speaker today. So the first thing that I want you to consider outside of choosing Speaker View is to please never show your screen. Lisa is the only one who will be showing her screen today, as it's her content that all of you will want to be tuned into. I also want to make sure that all of you checked your email inboxes today, because an email came your way with some additional materials that Lisa wanted you to have prior to the session today, some handouts. So if you haven't tapped into that yet, maybe take a moment to pop into your email boxes if you were the one who registered for the event, because that is the person who would have received the email. And those handouts will be available there. And Lisa, my understanding is they can also utilize those handouts after today's session. Is that true?
Absolutely. In fact, there are some things in those handouts that we'll be referring to for work between our sessions.
Okay, perfect. So nobody panic if you didn't have a chance to do that. We just wanted to make sure it was available to you ahead of time if that was your preference. So that takes care of the additional materials piece. Some of you might be interested in how you'll be tapping into CEUs. After today's session, the CEUs are specific to each of the 2 sessions in this series. Please note that you have to stick around to the very end of today's session in order to get the information that you need to apply for those CEUs. There will be a slide up at the very, very end, because that is our way of ensuring that you're going to stick it out and really be here so that you've earned those CEUs. So make sure you do that, and then we'll give you everything you know at that time so that you can take the next steps for that. A little bit about what you can expect between the 2 sessions of the series. Today is rich in content. You're going to get everything you need in terms of information to set you up for exploring this topic further in your organizations. And next week, you get to take a deep dive with Lisa that's more interactive and exploratory in terms of putting some things into action and planning a course forward. So that's going to be a really exciting pairing in terms of how the content lays out. And with that, I would very much like to take a moment to introduce our featured speaker and content expert. And let me tell you a little bit about Lisa Kendall. Lisa Kendall is a social work psychotherapist and clinical gerontologist who has passionately supported well-being for elders and their care partners for over 35 years in a variety of care settings. Formerly a senior consultant for work and family services at Cornell University here in Ithaca, New York, and now serving on the President's Advisory Council for Work and Family Affairs. Lisa maintains a private counseling and consulting practice in Ithaca, New York, and is an educator and a mentor for the Eden Alternative. Lisa teaches the nationally recognized fieldwork course for the Ithaca College Gerontology Institute, and she is also a founding member of the Finger Lakes Trauma Informed Network in upstate New York. Lisa also speaks to international audiences about the importance of person-directed and trauma-informed elder care, and you can read Lisa's blog on self-care for all members of the Care Partner team if you Google her at Crossroads Counseling, and we'll make sure that you have that link at the end of the session today, and we can also send it to you between sessions if you want more information. And with that, Lisa, I hand this over to you, and I am incredibly excited about what you have to offer us today.
Thank you, Laura. I am going to share my screen, and I'm going to ask you to bear with me for just 1 second because my screen is acting just a little bit buggy today. And as I share here, I'm going to go ahead, and there we go. I hope everybody can see my picture of a little girl here. I want to start with a story about a friend of mine. This is Sylvia. Sylvia was born in the south of England in 1925, and Sylvia was the oldest of 7 children in a working class family, and she was very happy little girl, happy to be the oldest, although she did have a lot of responsibilities with her younger brothers and sisters. And then when she was about 8 years old, her family switched their faith affiliation to a very strict religious sect, and she lost the very comfortable, homey, local Methodist church that she had been used to, and suddenly found herself confronted with a lot of very strict dietary laws and very strict discipline in the home that she hadn't experienced before. When I knew Sylvia much later in her life, she recalled being very harshly disciplined, being hit with sticks, being locked in a closet for discipline, and one time was forced to eat stewed tomatoes, which she really had an aversion to, and even vomiting at the table. And this was very clear in her memory, very striking kind of discipline for her as a child. It was really hard for her from that point on in her family. So this was a difficult memory for Sylvia as she grew up. And of course, living in the south of England in the 20s and growing into the 30s, by the time she was 15 in 1940, the war was really raging in England. And Sylvia and her next younger sister, Lynn, were evacuated away from the coastal areas where bombing raids were happening from the war with Germany. And Lynn and her sister went to a community where they were expected to be safe from that bombing. And it turned out that the community that they moved to and that the family they stayed with had a younger baby, and Sylvia was very happy to help the family out. She helped with housekeeping, and it was kind of a relief for her to only be caring for her younger sister and one baby instead of 6 little siblings. And one day they were out walking in the community. There was a little village nearby, and unfortunately the German raids had come to the community that they had been evacuated to. And they took cover in a store that had a large plate glass window, and the plate glass shattered, and Sylvia was injured quite badly. Her legs were cut, and when she took cover there with the baby and with her sister, one of her very difficult memories was of seeing someone lying in the rubble with them, and she didn't know, and her whole life didn't know if that person was just injured or if they had been killed in the bombing. As a result of this attack, Sylvia was taken by ambulance but separated from her sister and from the baby. And fortunately, several hours later, she did learn that her sister was okay and the baby was okay, but it was several hours before she was able to discover that they were in fact okay. So let me move on to Sylvia later in her life when I met her. Sylvia was just a lovely, lovely woman. Sylvia married a U.S. serviceman a few years after the war ended, came to the United States, got her education here, a very brilliant woman, and she became a psychologist. And just before getting her doctorate in psychology, she and her young husband were in a car that was hit by a drunk driver, and he was very seriously injured, and she was as well. And she remembered being in a hospital bed in traction, and a social worker with a an official looking clipboard had come into the hospital room to ask her how she planned to take care of her husband when he was discharged from the hospital. And she just remembered feeling so very helpless as she laid there in the bed, still in traction and still very seriously injured. And she's so frustrated by that question and so angered by it. And actually, a few days later, her husband did die from his injuries. He had a massive infection and a very serious head injury. So this sounded like a lot of very bad luck for Sylvia and a difficult start to her life. But she was a very resilient person, a very upbeat and happy, optimistic person. She invited her sister Lynn to come to the United States, and they shared a home, they shared a life. They both became professional people. Her sister Lynn actually was quite an artistic person and became a professional artist. They shared their home, they shared their lives, and they had a pretty good life here. Sylvia did have health issues that resulted from her accident, and by the time she was 50, she wasn't able to work anymore, and she had to start using a walker, and she had to go out on disability. But she continued to volunteer her time. She participated in a lot of activities in her community, and she and Lynn did very well together until Lynn started to develop symptoms of dementia later in her life. And Lynn would actually run away from the home that they shared. And when Sylvia would try to go after her, and she would have neighbors go and try to bring her back, usually this was in the middle of the night, Lynn would become very upset. She would become physically upset, and she would try to hit the people who would help her. She didn't recognize Sylvia, and Sylvia became pretty frustrated and upset and realized that she really couldn't handle Lynn's care at home anymore, and she finally agreed to have Lynn go live in a nearby nursing home. And that's where I became involved with Sylvia and Lynn and started to try to support them in becoming care partners and in learning how to bridge the communication gaps that had developed between them. And I really developed a close relationship with Sylvia. She's one of my favorite people. And we're going to come back to Sylvia because her story is important as we're talking about trauma-informed care and how trauma can impact health and well-being across the lifespan. And I'm so pleased that you've all joined us here today to talk about this important topic. And before we jump too much deeper into these waters, I want to just share with you a little bit about the language that we use. The organizations that have joined us today that are on a culture change journey will be aware of the language that we use, where we talk about an elder as someone who, by virtue of their life experience, is here to teach us how to live. And that is often somebody who's chronologically older, but not always. It could be someone who, because they're living with a developmental challenge or a cognitive challenge or a physical health issue at any age, is here because of their experience to teach us something about how to live. So it's not always somebody who's chronologically older. We talk about elderhood as a distinct developmental stage of life and a stage where growth and healing do happen. And these are definitions that come to us directly from the Eden Alternative. We talk about care as anyone or anything that helps us to grow. And we talk about care partners as people who are on our team, who help us to grow. And we understand that we, as the person who is accepting care, can also help them to grow. So there's a tremendous mutuality in that relationship. Everyone, no matter what their apparent challenges or limitations may be, has something to offer, and everyone in that care partnership has something to learn and some place to grow. And we'll be talking today about trauma-informed care, care that is strengths-based, understands about trauma, and we'll be talking about that a lot in more detail. And we're talking about care that is person-directed. And I want to take a moment to talk more about that phrase, person-directed. We hear a lot about person-directed care versus person-centered care. And I see I have an error on my slide, so let me correct it right now. Person-centered care is care where we've tried to figure out what would be the best care that someone might want in any given situation. And we try to set things up that would be through the eyes of that person. But person-directed care actually involves the people who are accepting care in making those decisions. And so we want to make sure that all care involves the people that are accepting that care or those closest to them. And when we're talking about trauma, we want to make sure that the language we use is respectful and honors the fact that they are, in fact, survivors, not victims. So we don't use the word victim. We always want to ask, what happened to you, not what's wrong with you. So this is a strengths-based approach. We're not looking for problems, we're looking for solutions. Today, these are the main goals for us today. We will be defining individual trauma, and we'll be looking at how trauma presents itself in a variety of care settings. We'll be looking at how the physical and emotional consequences of unresolved trauma play themselves out across the lifespan. So we are looking at a developmental approach to trauma. And we'll also be talking briefly, I'll be introducing some of the approaches that we use when we're healing trauma and supporting the healing of trauma, not just for elders or people accepting care, but for family members and for employee care partners in many different settings. So let's start with that whole idea of trauma and how it interacts with well-being. Let's start with a definition of trauma and talking a little bit about how trauma does impact health and well-being across the lifespan. So what is it that you think of when you think about trauma? Several years ago when I started doing some research on this topic, I would try to do searches on the internet for trauma and elderhood, or trauma and elders, trauma and seniors, and virtually all I could find was information about hip fractures and falls. There was nothing about emotional trauma in seniors. We're finally starting to find more research done in this area, but it still is very minimal compared to what is available for other life stages. And I think that is our challenge as people who may work with older adults, is to start to really figure out how we can take what we know about elders and elderhood and take that strengths perspective and that perspective of growth across the lifespan, including in elderhood, and take what we know about that and what we know about person-directed care and what we know in the growing knowledge about brain science and pull all of these things together to offer healing and hope in elderhood. So let's take a look at the definition of trauma. Trauma results from an event, a series of events, or a set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. Now, I like this definition because it's broad and because it does cover a lot of different areas. It is not the definition that you'll find therapists use when they're talking about PTSD or post-traumatic stress disorder. This is a definition that comes to us from SAMHSA, which is the Substance Abuse and Mental Health Administration. It's the definition that virtually everyone who's working on the idea of trauma-informed care is working from. Let's take just a quick look at this in a little more depth. Trauma results from an event, etc., experienced by an individual. So what this part of the definition tells us is that trauma is defined by the individual's perception. It's up to the individual to tell us whether the experience was perceived by them as traumatic or not. Two people may go through the exact same experience, and one person may find it traumatic and the other may not. This is important to keep in mind. The other part of the definition that's important is that it has lasting adverse effects on well-being. And we want to keep this part in mind as well. And we're going to look into a little more depth about why a traumatic event may or may not have lasting adverse or negative effects on well-being. So some of you had an opportunity before we got started today to do some thinking about what events can cause trauma. And I wonder if we could take a quick look at the chat box and see what came up for folks when they were doing some of that. What kinds of things can cause trauma? Let me see if I can just pull up my chat box here and take a look.
So Lisa, something that was submitted is bullying, neglect, abuse, violence.
Okay.
I believe there's something else that just came in, near-death experience,
Okay.
invasive medical procedures.
Mm-hmm. Yes. Medical trauma, sure. Yeah.
And deaths, loss of control, grief.
Excellent, yep. Yeah. And I see abandonment, shaming, war, right? And Sylvia experienced some of these, right? Loss of community, self, independence, Holocaust, yes. Bullying, abusive caregivers, yeah, excellent. You guys are coming up with a lot of things. Loss of a job, yeah. Again, what is traumatic for one person may not be traumatic for another. It's important to keep that perspective in mind, but any of these things can be highly traumatic. Embarrassment, sure. Not being good enough for someone. A miscarriage, the pregnancy loss. Yep. Good. Thank you so much for sharing those ideas. I wanna move on so that we can get an idea. Thinking about Sylvia, she certainly had a number of these kinds of losses. She lost the warm and friendly community that she had experienced in her faith community as a child. She had abuse in her home. She was extremely embarrassed and shamed around the food issues that she experienced in her home growing up. She had trauma from war. She was separated from her family, and that was especially complicated because when she left her younger siblings to be evacuated, she felt guilty about that, but she also felt relief because she was away from the harsh duties that she had in caregiving for her younger siblings. But she felt bad about that too. She felt terribly responsible for the safety of the baby and her sister, but she was separated from them for a significant period of time when she was also very injured. It's terribly frightening. She saw what could have been the death of one of the townspeople. She never did have that answered for her. She was in an accident. She lost her husband. She lost her job because of her disability. Later in life, she lost her only companion when her sister became ill with dementia, and it was very difficult for her to adjust to that. So, yeah, thank you. So, a lot of losses and trauma. Let's move on so we can see a little bit about how this works. So, what we're learning from brain science, which has advanced tremendously in the past several years, is that when we're confronted with something that may be threatening, is that our brain is flooded with a cascade of chemicals, primarily adrenaline and cortisol, excuse me, primarily to allow us to protect ourselves. And I have in your handout given you a link to watch a tremendously interesting, very brief 3.5-minute video on 3 ways that trauma changes the brain by Dr. Bessel van der Kolk, one of the foremost authorities on trauma. And basically, that allows us to take care of ourselves in a time of emergency. Okay, that's all well and good. We have these great survival mechanisms. That's terrific. So what's the big deal about trauma? These are the survival responses. We all are familiar with fight or flight. less familiar with Tend and Befriend. That's kind of a newish one. We don't have time to talk too much about that today, but that's been hypothesized to be a more female approach to trauma and an emergency. We also have the freeze survival response. Think about a rabbit in a field. When a coyote comes across the yard, the rabbit freezes. Maybe if the coyote doesn't see me, I'll be safe. We also have a feigned death response. Think about a possum that just sort of keels over, appears to be dead until the predator passes. Humans have these responses as well, and they're all survival responses. Again, all well and good. We get these chemicals that flood our system to allow us to have these responses. But what happens when we're in a chronic state of arousal from these survival responses, as in the soldier who's in a war situation, or a child who's in an abuse situation, or an adult who's in an abusive situation, or in a state of chronic stress for any of the reasons that we've been talking about? What happens to us is that our bodies adapt, our brains adapt to that chronic stress by staying in a hyper-aroused situation. Kaiser Permanente, I have to talk about this study briefly. Kaiser Permanente is a large insurance provider in California, and they learned that from a huge study, 17,500 adults, mostly middle class, mostly Caucasian, mostly educated people with excellent health insurance. Out of these 17,500 people, what they learned was that the more adverse childhood experiences they had, and these were 9 initial measures that they looked at, and that number has grown to 10. And they included things like having divorced parents, having parents who fought a lot, having a parent who had mental health issues, addiction issues, who had gone to prison, having been physically, emotionally, or sexually abused as a child. These are the kinds of issues they looked at, that the more of those issues that you experienced as a child, the higher your incidence of chronic health issues by midlife. And it was a striking study because what they discovered were a couple of important things. One is that these adverse childhood experiences are much more common in our culture than anyone realized. These didn't just happen to certain populations. These didn't just happen to people over there. These happened to all of us. So they're much more common. And this was a very strikingly strong correlation, that these health issues that happen by midlife all seem to be, these are things like cancer, liver disease, heart disease, obesity, lung disease, depression, anxiety. These were health issues that even if a person didn't have social issues or addiction issues themselves, which was also a more likely outcome of having adverse childhood issues, they still had the health consequences. So it wasn't just about modeling risky behavior that they might have seen in the household. These were actual biological changes in the brain and in the body. And what we've learned, again, from the brain science is that these adverse childhood experiences created a kind of toxic stress in the body that changed how the brain works and changed the body's ability to respond to stress by really being on hyper levels of vigilance, of being aware all the time that there might be a danger around the corner. So let's take a look at how this works. Basically, the toxic stress created high levels of inflammation in the body, which led to these illnesses by midlife. And if you just think about it for a minute, we're all in the health care field. It makes sense that we'd be seeing higher levels than normal of people coming into our home care agencies, assisted living, nursing home agencies, our health clinics, our doctor's offices, who have had these adverse childhood experiences or trauma at some point along the road. because we're seeing people who have chronic health issues by midlife. And these are folks whose lifespans have also been shortened by these illnesses and ultimately by these adverse experiences and by the experience of trauma earlier in life. So trauma happens to everybody. Bad things happen to everybody, but not everybody has the problems with chronic illness. So I don't just want to talk about the problems that these things can cause. I also want to talk about resilience, and there are resilience studies going on. We want to know why some people do get sick and some people don't get sick. James Garbarino is a researcher, a psychologist, and a writer who's talked about this issue quite a bit. He talks about risk factors and resilience factors, and I think it's important to keep those issues in mind. You have a reference to his work in your handout. But I want to talk briefly about some of those resilience factors and some of the risk factors that we might be seeing. My metaphor for this, excuse me, is that people are like redwood trees. So where did this come from? I did not know that redwood trees, for all of their amazing height and their size and their girth, think about how big redwood trees are. You can't even see how big my arms are right now. Redwood trees are huge. It turns out that they have little tiny spindly roots. If you can see my fingers, they're like no bigger than my finger. And they don't go down any deeper than about 6 feet. So if a redwood tree were to try to grow all by itself, it would fall over. Did you hear that? A redwood tree cannot grow by itself. Redwood trees have to grow in families. Redwood trees grow in groves. Groves are like redwood families. The way they can stand is that those spindly little shallow roots intertwine with each other. So they hold each other up. And in fact, the roots of redwood trees actually share nutrients. So they help each other and they hold each other. People are like that too. When bad things happen to people, the way they survive and thrive is that there's another person there to help them, to hold them, to help them process what happened, to say, I'm so sorry that happened to you. Are you okay? What do you need? I think you're going to be okay. Let me look at your boo-boo. Let me kiss it. Let me help you out. When a bad thing happens to a person and there's not someone there who is sympathetic and helpful and supportive, that's when trauma becomes stuck in a person's body and mind and soul. And that's when we say it becomes unresolved and it can have health consequences over the lifetime. It's as simple as that. And it's not as simple as that when you're talking about the chemistry of it, but it's as simple as that in terms of how it works for human beings. And so that is the difference. Human beings start to tell themselves stories about their powerlessness or their weakness. We develop negative beliefs about ourselves, that we're responsible somehow. Sylvia might have told herself that it was her fault that the baby was where she was when they had gone for a walk that day, that it was her fault that she left her siblings, that it was her fault somehow that her sister developed dementia. She might have told herself stories about her safety, that she wasn't safe. That feeling of not being safe comes up for people if they've been through war. Soldiers who've been in combat may respond to a backfire on the street as though it's gunfire, which they experienced in a very unsafe setting, and so they may hit the ground. We're all kind of familiar with that aspect of PTSD, or post-traumatic stress disorder. So that is something that isn't just about the thinking part of our brain. That's a survival response that the body has learned. We may develop a belief that we don't have value, that we are without worth. We may believe that we're powerless to change things. I think we've all known folks who, we can see from our perspectives, like, well, if that's not working for you, why don't you change it? But they they seem powerless. They seem powerless to change. But that's a belief that they developed at some point in their life, and it's very real to them. Or they create negative beliefs about the world around them, that it's an unsafe place, that it's a cruel place, that it will never work for them. And people carry those beliefs sometimes throughout their lifetime. When people become older or they do develop some health issues, they're challenged by some additional things. And that certainly includes the pervasive ageism and ableism that we're all familiar with. Their life roles may change considerably. We have studies that show that soldiers from World War II came back from the war. They seemed to get married, they bought houses, they went to school on the GI Bill, they raised their families, and we have shown, studies have shown, that some of them didn't develop post-traumatic stress disorder until 50 years after the war. What was that all about? It turns out that maybe the roles that they took on helped keep them busy, helped keep them engaged, maybe were antidotes to some of the plagues of loneliness, helplessness, and boredom. But when those roles went away, maybe that was an opportunity for the trauma to resurface again. I think we need some more studies on that from the perspective of our culture change journey. Caregiving can become a challenge in elderhood, and of course the physical changes that people can experience and the losses that we talked about. You can see, I think, as I'm sharing some of the stories about Sylvia and some of the ways that people can experience trauma, that if you have had an experience of unresolved trauma, it can get under your skin in a way that affects your very sense of self. It can affect your sense of identity. It can impede the growth that you need to have to experience true well-being. It can impair your sense of autonomy. It can certainly shatter any sense of security that you have in the world. It can damage or disconnect your feeling of connectedness. It can dampen your meaning, and it can certainly do the same with joy. So every domain of well-being that we talk about in the Eden Alternative can be affected by unresolved trauma, and that's one of the reasons it's so important to start to address this. So I want to talk about what trauma might look like in different settings, and I want to talk about, again, why it is so important that we address this. And then next week, we're going to talk about how we can start to tackle this. So what does trauma look like in your setting? And if you have a moment to enter, if you've got some things that you're already aware of in your setting, what are the symptoms, or what are the signs? How, if you were watching some of the folks that you work with or that you provide services and care to, or even among your colleagues, other care partners, families that you deal with, is there just a word or a phrase that might describe what does trauma look like? What are the impacts, excuse me, in your setting? How do you know that you're looking at the impacts of trauma? Can you enter a word or a phrase into the chat box? I'm going to open my chat box.
So far we have physical chronic pain, anger, short fuse, difficulty making decisions, disengagement, physical tension, loss of spouse, mental health, dis-ease, stress, hesitation, anxiety, withdrawal.
Okay, excellent. Yeah, these are certainly
Burnout.
signs. Yes, burnout. That happens to care partners and family care partners. Loneliness. Yeah, anger. Sure. We forget that anger can be a sign, don't we? Yeah, really good. Thank you. Apathy. Powerless. Yeah. Crying. I've seen people who are ultra polite and formal too. And that's a mask. They're hiding a lot of insecurity. Yeah. Thank you. I'm going to move on and show you sort of the list that I created. I think you guys have hit a lot of what is on the list. So sometimes people who have unresolved trauma may have very extreme reactions to seemingly small issues. They may really blow up about something that people are like, whoa, what was that about? They may be very passive or have low self-esteem. They may be very shy about speaking up or taking care of themselves. Sometimes if someone's been assaulted, especially if there's been a sexual assault, or I've known people who have been victims of, well, I said it, at least survivors of criminal assault, who've had a very hard time with physical contact and have been very reactive to touch. And someone who's been assaulted may have a hard time with receiving personal care. People who are easily startled, that could be a sign of unresolved trauma. Depression, feeling pessimistic or paranoid, suicidal thoughts. People who live with a lot of anxiety, nightmares are a sign, can be a sign of unresolved trauma. And I want to caution you that not every sign we're listing here is a direct line to this. Nightmares, by the way, can also be a sign, or night terrors can be a sign of a reaction to beta blockers. So let's be a little bit careful about this, but just in general, these are some things to look for. A history of broken or difficult, challenging relationships. Exploiting other people or allowing yourself to be exploited. Anger was mentioned, what we sometimes refer to as combativeness. I like to be careful about that label. Forgetfulness, confusion, or disorientation, sexual acting out, substance abuse, addiction, very common for people who have addiction issues to have some kind of trauma in their history. In fact, people often start to use substances as a way to numb the memory or the pain of unresolved trauma. Physical complaints, unexplained pain is sometimes a way that the body has taken in and is kind of managing old trauma. So that's just some things. And let's take a look at how Sylvia might express her unresolved trauma. And these are not conscious for the most part, so let me make that point. In order to cope, Sylvia may prefer not to attend religious services. And in fact, Sylvia longed for religious services later in her life. She called herself a non-believer. She wanted the community that she thought a church could offer, but she felt kind of guilty. She didn't want to go to church under false pretenses. Late in her life, she actually found a church that she started attending, and she found it to be a very warm experience for herself, and she was really embraced by a very small local church community, and it was really a good experience for her. Sylvia may choose what she eats, feel anxious about what she's served, and be very sensitive to remarks about cleaning her plate. And this is actually kind of a common thing. I think we all know folks, and I've shared with Laura, and I have talked about this. Being in a local diner, I have a server that we know very well, and every time we're in there, she comes up to us and she kind of jokes around and she says, "Oh, you didn't clean your plate, no dessert for you." And I always cringe because food issues are really not uncommon in people's families, and I just hate that whole thing around food, and that kind of makes my own stomach lurch. And I just think for those of us who are working in residential care settings and we have people who are living there, I think we want to be careful about not inadvertently causing that same kind of reaction to somebody who may have grown up in a family where there were conflicts around food, or there was discipline around food. That certainly happened to Sylvia, and that's an area of sensitivity for her. Sylvia may startle to loud noises. Again, think about her war experience. She may dislike war films, or she may feel drawn to them. People who survive war experiences may sometimes go back to that material as a way to process the trauma. She may prefer to carry a baby doll at some point. She may search for family members. In fact, later in Sylvia's life, she had some TIAs, some mini strokes, and she was diagnosed with dementia. She was able to talk with me very clearly about her experience of the cognitive changes that she was experiencing. And she was able to talk about that right up to the point where she herself went to live in a nursing home. She would become frustrated by challenges with finding words and with communicating. That was especially difficult with her sister. Sylvia may feel overly responsible for things or may carry guilt or shame, and that may be something that she would never share with somebody else unless you got to know her well. And becoming well known is really key when we're talking about trauma. And Sylvia may or may not want to talk about her experiences. Again, that's a question of how close you get to Sylvia and how much she trusts you. It's important to keep in mind that what we think of as symptoms really have been solutions, that these are coping mechanisms, and they may have been life-saving at one point for the person who is experiencing them. And even though they become maladaptive, and by maladaptive I mean what worked at one point may cause problems later. Think about the person who is an assault victim who drinks alcohol to numb the physical or emotional pain of that, who then develops a problem with alcohol. It worked for a while, and now it's creating more problems. It was adaptive, and now it's maladaptive. So that's what we mean by maladaptive. But it was a solution at one time. So we have to give people credit for trying, for trying to find solutions. And so that's why we're strengths-based, and we want to acknowledge that for people. So we want to always find out what is the person's story, what is at the heart of what they've been dealing with. We want to look at how the plagues of loneliness, helplessness, and boredom may have played a part in their life, and how trauma underneath these plagues could have contributed to their loneliness, to their sense of helplessness, and to the boredom that they are feeling. I spoke on this topic at an Eden Alternative conference a few years ago, and I had a really wonderful conversation with someone from a home that was on the journey of culture change, and they were offering all of the antidotes to loneliness and to helplessness and to boredom to one of the elders who lived in their home. And they were fully aware that the person that they were working with had been, in fact, a sexual assault survivor. And they were working with her in a very open-hearted way to help her deal with accepting and receiving personal care. It was something she needed help with, and they would talk with her about it. And no matter how person-directed they were in delivering that care, she still was struggling with receiving it. She would have flashbacks and start screaming every time they would try to give that care. And when we talked about trauma-informed care, what we realized was the antidotes are absolutely vital. They're absolutely essential. But where there's trauma, we have to kind of go one step more. And that's why I think of trauma as a fourth plague, because there are treatments that can help heal from trauma that has to happen before someone can really get past that trauma so that they can receive the antidotes. And that's a biological thing, and as well as sometimes an emotional space for people. So let's talk a little bit more about that. That's the idea of why trauma-informed care is important. Mrs. Jones really struggled with bath time, even in the context of a person-directed care environment and a person-first environment, because she was sexually abused as a young girl. So some of what I'm going to talk about for the rest of our time together will help us understand a little bit more about that. Before we get into that, I do want to talk about why it's important to resolve painful memories in elderhood. First of all, I want to say that there is still a lot of ageism and ableism out there, and there are people who are talking about trauma-informed care in long-term care who still don't believe that healing can happen in these settings. I just have to say I completely disagree with that assessment. Just because there's not a ton of research on this doesn't mean that it can't happen. And I want to point first and foremost to Bill Thomas's idea of the tasks of elderhood. He says that the 3 tasks of elderhood include being a peacemaker, being a wisdom giver, and being a legacy creator. And I think when we talk about being a peacemaker, that includes making peace with our own pasts, making peace in our families and in our communities and in the world, but first and foremost, making peace with ourselves and within ourselves. And in doing that, I think we are helping contribute to our legacy in our own families, and that contributes certainly to the wisdom in our care partner communities. This didn't just come from Bill Thomas, of course. Eric Erickson, talking about his 8 developmental stages, talks about the final stage of life as integrity versus despair. And integrity is really being able to look back at your whole life and say, you know what, even though some bad things happened, I learned from them, I grew from them, and overall, my life holds together. It has integrity. My life made sense. If you don't have that opportunity to heal trauma, to make sense of your life, you look back over your life and it doesn't make sense, and you are left with despair. And I work with people who have that sense of despair in my clinical practice as a psychotherapist. It's a horrible place to be, and I think we owe it to elders to offer opportunities for trauma healing no matter what setting they live in and no matter what stage of life they're in. Robert Butler talked about this going all the way back to the 60s when he developed his life review approach. Naomi Feil has been talking about this for decades as well. Her validation approach to working with people who live with dementia was originally conceived as a way to give people the space and the validation that they need to reenact unresolved trauma. If you read her book on this topic, what she really says is you are entering into their reality because they have something unfinished that they're working through. So it is an approach to communicating with people who are living with dementia, who we might think of as like, well, they have a different reality. But Naomi Feil's original approach to this was they have unfinished business. They have unresolved trauma. And by entering into their reality and validating their emotions, we're not only making a better communication, we're giving them space to do their unfinished business and to finish some stuff that they need to finish. It's a very powerful approach. And I'm going to pause for a little sip here. So resolving trauma in elderhood is important, I believe, because it does fulfill those developmental tasks. It helps us to support making peace with the past. It affirms that healing and growth are, in fact, natural part of elderhood. It increases well-being, not just for the elder, but for family members and for care partners, not just in those relationships with each other, but for each member of that care partner team, because we all have unresolved trauma to one degree or another, and we're all vulnerable to it. And it certainly can decrease morbidity and mortality, sickness, and early death. And there are lots of studies about this. So let's talk a little bit about trauma-informed care. I'm going to talk about some approaches to what this means in your different settings, what it is. I'm going to share the definition, and as I mentioned, next week we will be talking in a lot more depth about how to actually introduce a trauma-informed care approach in your organization. But let's just dive in quickly to what it is that we're talking about. So the definition of trauma-informed care that comes from the Trauma-Informed Care Project is that trauma-informed care is an organizational structure and treatment framework that involves understanding, recognizing, and responding to the effects of all types of trauma, and it emphasizes physical, psychological, and emotional safety for both consumers and providers, and it helps survivors rebuild a sense of control and empowerment. And that's about the best definition of trauma-informed care that I've heard about. Trauma-informed care, when you think about it, is dependent on a person-directed care environment to work. So they feed into each other. Trauma-informed care is built on the person-directed care model, and person-directed care, by definition, really is going to require that your care be trauma-informed. If you're already involved with person-directed care, you're way ahead of the curve in terms of being able to implement and understand trauma-informed care. It's not just that there's overlap here. These models run parallel to each other, and ultimately they are the same thing. So these principles of trauma-informed care are really important. We're really talking about safety. Safety for elders and other people who are accepting care, safety for staff, safety for family members. And this is an organizational promise of safety in lots of different ways. We're talking about trustworthiness and transparency. This is, again, an organizational promise that what you say you're going to do, you will do. You will be accountable for your actions and for your policies and so on, and that you will be transparent in your dealings. Peer support and mutual self-help is a hallmark of this, and I think when we talk about it from the perspective of the Eden alternative, we're really talking about ways that care partners rely on each other and support and help one another. So this is another way that we look at this. I'm going to take a quick peek at my notes here too, because this is such an important part of this that I want to not miss any single piece of this. That peer support and mutual self-help idea is really a key to the service delivery approach. And it's a necessary part to building that idea of safety and trustworthiness and transparency. The whole idea of collaboration and mutuality, that's where we're talking about true partnership. And the idea is, again, between staff and elders and family care partners, but also within each of those groups so that people are counting on each other. We're talking about a flattened hierarchy. We're talking about empowerment. And again, those of you who are in organizations that are on a journey of culture change will really recognize this as the hallmark of what our organizations are all about. We know that healing happens in relationships. And this is certainly true in my work as a clinician. And this is why trauma-informed care is so important in my work, because it's the relationship that's work. It's the relationship that works. It's not even about the modality as much as it is being deeply known and establishing trust, establishing safety, and establishing that this is a partnership. This isn't about somebody's the expert and somebody else is the passive recipient of somebody's expertise. Trauma-informed care is not just for therapists. Anybody can be therapeutic. Any activity can be therapeutic in this model. Empowerment, voice, and choice is really, again, about strengths being recognized, built on, and validated. So this is very important. We're all building new skills. We're recognizing that everyone is unique, and we're really believing in the idea of resilience and recovery in this model. We're also looking at cultural, historical, and gender issues. And someone had mentioned that one of the things that can cause trauma is the Holocaust. And I think that's such an important thing to keep in mind. Other things that can cause trauma are homophobia and racism and a culture that has had a history of slavery, institutionalized racism or other isms. And we need to be able to move past stereotypes and biases and be responsive to gender and ethnic issues, and even to call on the values that traditional healing modalities may have, and to be able to pull those in to the kind of care that we're offering to people, and to recognize historical trauma when and where that's happened. So these are some important ideas, and they are all spelled out in a lot more detail with links that are available to you in your handout. So trauma-informed, person-directed, and strengths-based care is something that needs to happen in every setting and in every life experience. Everything from the welcoming that someone gets at your organization's front door to the healing that someone may be seeking from post-traumatic stress disorder or from another very serious health issue. Someone mentioned medical procedures and the trauma that can happen from them. I've known people who've had very significant trauma from what should be pretty benign medical procedures. We need to be mindful of that. Every part of life, from dining experience, as I mentioned, to personal care experiences, very intimate care. It's for everywhere, for every place, and for everyone. I attempted to organize some of my ideas about this into this little chart, and so I kind of made some columns. I thought about some of the recreational activities and some of the things that are being pointed to as very therapeutic, as healing for trauma. Anything that is done in a group, drumming circles, singing as a group can be very therapeutic in trauma healing. Age-appropriate expressive arts like art, dance, theater, music, journaling, working with clay, storytelling can be wonderful. Think about story circles and being able to normalize experiences that people have had by telling stories and sharing tales. And this doesn't have to be therapy, but it can be therapeutic. Reminiscence and music and memory is a program that we're aware of that allows people to bring more articulation and bring back memories in a way that allows people to share. Anything that is strengths-based is trauma-informed. Yoga and Tai Chi are not therapy, but they're body-based approaches that are trauma-informed. When we think about the physical environment, we think about the greenhouse model. That is a trauma-informed approach as opposed to the institutional medical model of care. Calm and serene spaces are very important in a trauma-informed approach. Personalized and private spaces. Anything that's non-medical, that's intergenerational and multi-species. When we're looking at clinical approaches, I'll talk about this more in just a few minutes. We're looking at approaches like eye movement desensitization and reprocessing. That's a clinical approach that's used to treat post-traumatic stress disorder. Cognitive behavioral therapy, advanced experiential dynamic psychotherapies. If you're not a therapist, some of these may sound like word salad. I've mentioned already narrative therapy and some of the things that Robert Butler really started out with. Expressive arts, journaling, mindful awareness, motivational interviewing. These are some clinical approaches that if someone's getting therapy, they may be exposed to. On an organizational level, it's important to really give yourself credit. Person-directed approaches are trauma-informed approaches. Empowered care partner teams, doing education for all staff, supporting all care partners, doing screening for trauma is part of a trauma-informed approach, but you want to be mindful how you do that. And so there's an art as well as a science to that. Having an evidence-based screening tool isn't enough, and we will talk about that more next week. Doing learning circles is a tremendous trauma-informed approach. Situational leadership is a specific leadership model that is a trauma-informed approach, and servant leadership, which we certainly value in the Eden Alternative, is a trauma-informed model for a lot of reasons. So I want to just briefly, and this is a recapitulation of some of what I talked about, the Spark of Life program that I heard about from Australia. And Snozelland rooms are high stimulation for people who have cognitive issues. Both of these models provide high stimulation, which sort of act in a counterintuitive way to help people who live with dementia calm down and helps them express themselves more. I think anything we can do to improve communication in a safe way helps people talk about their trauma. And in the Spark of Life video that you'll find on the internet through YouTube, one of the first things that the gentleman talks about is his experience in war, which I think is really interesting. And being able to do that in a safe space, I think, can be helpful. We mentioned drumming and therapeutic art. Locally, we have a program called Memory Maker, which supports people who live with dementia encounter and participate in making art. One of my favorite programs in the country is Opening Minds Through Art, which is through Scripps Gerontology Institute at the University of Miami in Oxford, Ohio. They have a wonderful program there which connects college students with elders who live with cognitive challenges, and they make the most incredible, beautiful abstract art. It's just amazing. There have been studies that show that movement and dance, especially combined with writing, can be very effective. Using theater, role play, psychodrama is expressive. Al Power's experiential approach to dementia, and I already mentioned validation therapy with Naomi Feil. Validation is a very powerful way to help people, for us to support people who live with cognitive challenges by building bridges for them, or as Dr. Power talks about, making cognitive ramps so that we can support their ability to communicate with us. I've done trauma work with people who have dementia, and it's really beautiful work to help someone make peace with their past. Mentioned already life review and narrative therapy. These are ways to recast what's happened to you and to make sense of the past so that you can make peace with it. There are ways to process trauma that has been stored in the body, ways where we use our thinking part of our brain to control the body, as in yoga, qigong, tai chi, and tapping, and then ways that we move the body to make a change in our thinking, such as breath work, movement, through touch and massage. There's more information about that as well. Again, I already went through some of the things, treatments for post-traumatic stress disorder. If someone does actually have that diagnosis, here's a list of some of the things. And medication can be effective for PTSD as well. There are some antidepressants that can be helpful for this. And there's more research going on about this all the time. I've given you some links. One of the best resources for this is the Substance Abuse and Mental Health Services Administration, and also the Veterans Administration has an excellent website specifically for PTSD, and I've given you the link for that. I want to talk about post-traumatic growth for a moment. It's important, again, keeping in mind that strengths-based perspective, that folks who live with trauma are survivors. Even more importantly, folks who have survived trauma, many of them go on to have a significant amount of growth beyond the trauma, that compared to their peers, they actually exceed their peers on measures such as compassion or self-awareness. Think about the people who went through the very bad bombing at the Boston Marathon a few years ago, how many of them went on to become public speakers or to found foundations or other social services organizations. These are people who developed their own way to give back. Trauma can be a point of tremendous accelerated growth, and we want to keep that in mind. Trauma is not all decline, just as elderhood is not all decline. We need to keep in mind that these are things that spur us to greater growth. Again, not what is wrong with you, but what happened to you. And I've developed some questions that I built around the Eden Alternative 7 domains of well-being that I believe are built on people's strengths. Asking these questions might help elicit people's stories and might even help them reframe their experiences. Uh, so you have these questions as part of your slide handout. I like to ask people, how has this experience shaped your identity, who you are now? How have you coped? What did you learn? How have you grown? And what would you tell someone else who's been through what you've been through? What gives you strength? What's meaningful for you? What gives you joy at this time of your life? Who has been a role model for you? Maybe there wasn't a human person there for them at that time of their life, but maybe there was a TV character or someone in a story. We hear a lot about people who've been through some pretty hard things in childhood, and if they were able to thrive, it was because they were readers, and they crawled into a lot of storybooks, and they had heroes in the pages of the books that they read. Who were their heroes? How did they learn from them? What can they share about the people that helped them survive and thrive? And what do people need to feel safe now? I think it's important to know that what comes next is, at a minimum, to know the resources for referral for your organization. Who can you refer to in your community and within your own organization? How can you create a safe and supportive environment, not only for your community that you serve, but also for their families and for your own employees? Care partners can and do have their own trauma issues, maybe from their own past, but we also have to think about, depending on our environment, what are they exposed to now that could be traumatic for them? Care partners that are employees may be exposed to things on the job that can cause burnout or can cause secondary or vicarious trauma. And most importantly, we want to embrace this process of becoming trauma-informed and trauma-responsive. I want to share quickly the last day that Sylvia had with her sister before her surgery. Sylvia's back injuries did become worse as she aged, and when she was 85, she went in for surgery. But she had a day with her sister where they were able to sit out on the patio at the nursing home where Lynn lived, and some wild geese flew overhead. And in Celtic spirituality, the wild geese represent the Holy Spirit. And it was just a sweet and peaceful moment for both of the sisters. And I get a little choked up when I talk about it, because it was just a sweet moment that Sylvia shared with me. After all the work that we had done together, I felt like Sylvia had shared so much about her war experience and about the difficulties and the challenges that she had had. But I felt like when she went into that surgery, she had come to a place of healing. The experiences didn't go away. They didn't change. But I felt like she had reached a place of integrity, that the community that she had found, the permission she had given herself to rejoin a faith community, it meant something to her to watch those geese fly overhead, and it was kind of symbolic of the journey that she had had. And I just wanted to share this last image with you. I want to summarize by saying that trauma is common. Unresolved trauma is more common than it should be or needs to be. It does impact our physical and emotional health and our well-being. The good news is elderhood is the time for growth and healing. A lot of the conversation around trauma-informed care is for kids, and it should be, but it doesn't have to be limited to children. We should help our kids be more resilient, absolutely, but those of us who work with elders can help elders, and we can help each other. We can support each other in healing unresolved trauma and making our environments trauma responsive. Trauma healing happens in a human habitat. That is the antidote. That's where the antidotes are to loneliness, helplessness, boredom, and to trauma. And trauma-informed care is an important part of culture change. I am going to start saying it's an important partner to culture change. I think I want to stop sharing my screen for just a minute. This is what's happening next week, but I want to go ahead and open up to questions. So people have been, I think, maybe making some comments or questions, and we've got some time. We have about 15 minutes before we end, and I want to see what kinds of questions have been coming up for folks as we've been going through this material. There was a lot that I shared this week, and next week there will be a lot more opportunity for some hands-on work with looking at some evidence-based assessments for your organization, for care partners, and also for elders to do screenings and really figuring things out. Sue Ellen, yes, the time for next Tuesday, we start at 2 o'clock next week and we'll go to 3:30 again. Thank you for asking. Let me see if I can get into my chat box here.
So if it's all right with you, I'm going to jump in, Lisa, and invite people actually to start pumping some questions into the chat box. Would that be okay with you?
Yeah, that's great for me.
Yeah, this is your opportunity, if you have questions for Lisa, to add them to the chat box right now so that we can just take them as they come in. Please don't hold back. And while we're waiting for those to come in, Lisa, anything that you want to share while we're watching questions come into the chat box? Oh, yeah. You've already got a question. Any recommendations for structuring? Wow, they're coming in fast. Staff training.
Okay.
Wow.
You know, that is gonna be unique to your organization. I think there are a lot of resources that I've put into the handout, and I think there are a lot of ways you could do it. You could certainly start with an in-service that's going to get everybody on board with understanding what trauma is. I think one of the visions I have in my mind would be that if everybody can understand sort of the basics that we went over today, understand what trauma is, and then sort of have your leadership team, especially if you have a multidisciplinary team that crosses, you know, all the folks in your organization, and bring some elders into that team to figure out how you want to tackle it. Again, I would use a person-directed approach to that so that you've got the best wisdom from all the different parts of your organization. Bring people together to figure out what looks like it makes sense for your organization. Get some coaching from someone who really understands this field. And I would also encourage you to connect with whoever your regulators are. So if you have state surveyors, if you can connect with ombuds people to talk about this topic, make sure you're connecting with your regulators. We'll talk more about this next week for sure. And I'm going to just pause on that question for now, make sure we get to the other questions. Let's see. What else we got? Oh, somebody's asking about age appropriate. What do I mean by age appropriate? I was talking about age appropriate activities. Is something less appropriate for elders, or did I mean cognitive appropriate? Okay, I'm comparing what I've seen done in the opening, the OMA program, Opening Your Minds to Art program that Scripps does, is they do art projects with elders who do have cognitive challenges that are so beautiful that I would hang their art in my house. I would wear the scarves that they make. They are gorgeous. I saw a presentation that they did out at the American Society for Aging conference a few years ago, and one of the things they did was they compared the art that the elders did to art by world-renowned abstract artists. And with the exception of one piece, I would have preferred to buy the art that was done by the elders because it was that good, it was that beautiful, and I couldn't tell what was done by whom. I compare that to what I see done in adult day programs, for example, where people are gluing, really, I don't want to hurt anybody's feelings, but they're gluing pipe cleaners to paper plates. And people who, and there's no reason that adults, I don't just mean elders, but adults can't use materials and make art that looks like adult art and doesn't feel like a kindergarten project. I'm sorry, I just have to be blunt about that. It doesn't take money. People who, and it is partly about being cognitively appropriate. People with cognitive impairment shouldn't have to draw inside the lines anymore because their strength now is abstract art. They're better at abstract art than they are at representational art. So let's build on that strength and let them be free with paints. Let them be free with color because they're really good at that. And I love coloring. I'm a person who loves coloring books and things like that. And so I'm not talking about coloring books, but maybe that's not the right thing for certain cognitive abilities. But some stuff just looks like a kindergarten project and people know it. It does, and they come home. And as much as people love adult day programs, and I've worked in them and it was the greatest experience of my life, if they're coming home with something that looks like it should have been a kindergarten project, that's offensive to people. So when I say age-appropriate arts, that's what I mean. It should not be for 5-year-olds. So yeah, thank you. I see a thumbs up there. So yeah, what else have we got?
So Lisa, we have a question that goes, how could you see these principles being applied to low-income housing residents?
I don't really see a difference between applying them in low-income housing. I think when we talk next week about the screening tools, we'll see how they can be applied anywhere. So I guess I would need more information about what services are being applied there. These principles apply everywhere. They, whether people live in low-income housing or a very sort of high-income continuing care retirement community, everybody is subjected to the same kinds of traumatic events. One of the issues, perhaps in a low-income environment, is that you could have the added trauma of poverty. You could have the added trauma of ethnic kinds of discrimination that people may have experienced in those settings. So it may be more on the surface. I think sometimes when people are living with a lot of financial resources, economic resources, sometimes the trauma goes underground. But when you get folks together and they start to talk about it, then you'll hear these folks say, yeah, my dad was an abusive alcoholic, but nobody ever knew how much my family was suffering. One of your homework assignments is going to be to watch a TED Talk by Nadine Burke-Harris. She will talk about this in unequivocal terms. She's written a book about childhood trauma, but please do watch this video, and I think that will bring this whole idea of the impact of trauma across the lifespan and across socioeconomic strata to life for you. So for that question, I would say please do watch Dr. Nadine Burke-Harris, and her TED Talk on this, I think, will answer that question as well. And we're gonna have you guys working next week on how to put this into place in your own settings. If that makes sense?
Sounds
that assignment is in your handout, and we'll email that to you again so that we're sure that you have it.
Lisa, I just want to add that the question regarding age appropriate, there's sort of a follow-up, and I don't know if you want to add to this. It says, right, so you actually mean age appropriate, really, as opposed to when care partners infantilize the people they are serving, aka helping people beyond their own misconceptions.
Yep. Yeah. Yeah. Yes. Um, if your organization hasn't been working on this, hasn't been focused on a person first, person directed kind of approach, um, I would invite you and encourage you to look at what the Eden Alternative philosophy has to offer. Um, it's a beautiful way to get people past ageism and ableism and those approaches that do lead to things like infantilizing people and lead to misconceptions and mistakes in care, um, that are devastating and traumatizing, frankly, and not good for the workers, not good for the caregivers, not good for the people who are receiving care. And one thing I want to do next week is make sure that you all are aware of the different kinds of trainings that the Eden Alternative has to offer if your organization hasn't been exposed to those yet. I'm not going to turn our training next week into an advertisement. That's not the goal. But I do want you to be aware of what's available if you haven't done that yet.
Lisa, we only have a couple more minutes before it's time to share the CEU information. Somebody has asked a very general question. I don't know if we need to ask them to narrow it. It's, what have you seen already implemented? So maybe we could take that as, is there a particular implementation of trauma-informed care that you want to share that you haven't already?
Yeah. Most of what is being implemented for children in schools. So what we're seeing are things like schools that are doing yoga and mindfulness training in schools, which is a great way for kids to calm down. I just watched a film where there's a program where students in schools had, let me see if I can remember the name of it. I can't remember the name exactly, but where students have a little part of the school day every day where there's a story that is read to them by an adult, and the story has a character in it where the character is very interested in hearing about students' problems. And so students write letters to this character where they can share what's going on at home. And these letters go into a box, and then the school is alerted to what's going on with the students at home. And it's not a way to tell on anybody who's having, abuse issues at home, but it is a way to have an early intervention and to support both the students and the families if there are issues at home. And it helps the kids be more calm at home, at school, and to get support at home, and for the families as well. It's not like, hey, let's call Child Protective and blow things up. It is a way to calm things. So there are a number of ways. One of the links you have in your handout is for ACEs Connection. That is a website where every day there is a ton of stuff pouring in to show you how things are being implemented all around the country. And the ACEs Adverse Childhood Experience Study is continuing in a number of states all around the country. This is just finally burgeoning. This came out about 20 years ago, and the doctors, and it was not just Kaiser Permanente, I neglected to mention, the CDC, Centers for Disease Control, joined with Kaiser Permanente. I think these guys deserve Nobel Prize in medicine for what they did. But when they first came out with it, they were laughed at. Nobody wanted to talk about it. Nobody wanted to think about it. But now finally it's really getting traction. This is best practices for medicine, for schools. This is just now coming to us in long-term care and for later life. I think partly because ageism keeps us from wanting to deal with this at the end of life. People say, well, they're old, can't change them, what are we going to do? I think all of you who are here can be champions for this, for the elders that we serve, and for people of any age that may already be living with some of the health issues that trauma at any age can cause.
Lisa, this is so amazing. We have 1 minute left, and I'm going to need to reserve that minute for some closing activities. I do want to point out that we got a clarification from the person who posed that question that what they would love to hear is implementation in nursing homes related to the upcoming phase 3 requirements. So my request is that we put a bookmark on that one, and we bring it next week, maybe for some clarification. But I just wanted to make sure that individual knows that we saw that clarification that they provided in the chat box. I also want to point out to everybody that in the chat box, if you'll go in and look in the chat box, I have included the link to the handouts for today. So you can bypass looking for your email, copy that link, and go right now and download those handouts. A couple of people are saying, I didn't get the email, and that's probably because you weren't the registrant for the webinar, because those are the email addresses we had. So if that's the case, go into the chat box right now, copy that link, pop it into your browser, and you'll be able to download the 2 handouts that were part of today's additional materials. So now what I'm going to do is I'm going to, first of all, thank Lisa for an amazing sharing presentation today of some rich information. And Lisa, I don't know if you're seeing it, but in the chat box, people are responding very positively to everything that you've offered them. And so now it's time to share CEU information. And I'm going to pop that up on the screen. And it's incredibly important, if you're interested in CEUs, that you pay very close attention right now. All right. Lisa, can you confirm that the CEU information is what's visible on the screen right now?
You know what? I just tried to get out of my chat box, and I'm looking at my own. I'm looking at my own slides. So let me see if I can get back in.
No problem. I can ask some folks. I see some faces. If you can nod and tell me that you see the CEU information up on the screen right now. Yes? Is that what people see? It says, send an email to sgerold@edenalt.org no later than March 12th, 2019, if you're interested in CEUs. And the subject line of that email should read, CEUs for Trauma-Informed Care, Session 1. Here is one of the most important parts that you need to know, is that in the body of the email, you need to promise that you are here start to finish today for this webinar presentation, and you have to offer a code phrase that will be evidence that you were there at the end of the webinar, and the code phrase is, offer understanding, comma, create ease. I'm going to repeat that code phrase. Offer understanding, create ease. The email again is sgerold, SGEROULD @edenalt, EDENALT.org. Again, the subject line, CEUs for Trauma-Informed Care Session 1. And your code phrase is offer understanding, comma, create ease. I am going to leave that up on the screen. Lisa, do you have any closing words that you want to share? I'm seeing some very enthusiastic yay Lisas in the chat box.
Well, I'm just so grateful that you're all here. I'm counting on all of you to just take this information and to absorb it and to fertilize it and to grow it, because I just really believe in this. I think a lot of healing can happen from this, and I'm excited about seeing you all again next week. So come back and we'll keep growing together. Thank you.
Thank you so much. Next week, March 5th, from 2 to 3:30 p.m. Eastern Time. Please do your time zone math if you're in another time zone than the Eastern Time Zone. We look forward to seeing you again then. And you can count on the session recording being shared with you. It is part of what you pay for, a link to the session recording. You have access to it as registrants in this series for up to 1 year. That means you can pack people in to watch the recording as many times as you want. It is the gift that keeps on giving. So make sure you make use of that resource. Thank you all and have a great evening.
Bye, everybody.